Who all do we have here?
Hey, Jeff, this is Margaret. It looks like yourself, Tom, Sean, and JJ are all here.
Oh, okay. I was looking for Sean's name. There it is.
Yeah. So I do think we have everyone necessary to get started.
Yeah. Just a second. I'm going to close the door. Excellent. So let's call this meeting to order. So I guess I have to go through the formal call to order the September 21st meeting of the Innovation Workgroup. First order is to approve the synopsis of the last meeting.
So moved.
Moved. Is there a second?
Second.
Jeff, can I can't do vote or anything, right? So I can't even second. I think I seconded I looked at the minutes from last time and apparently I jumped in there. So I'll keep my mouth shut from now on. I apologize for trying to get in the way of Roberts.
Oh, thanks, Tom. I appreciate that.
We'll talk, Tom.
We think of you as part.
I understand.
So all in favor?
Aye.
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 Okay. That's enough. So, performance guarantee update.
Yeah, good afternoon, everyone. So moving forward to attachment 2 for today's meeting. This is an update on the status of OEBB and PEBB performance guarantees for the upcoming contract year. If you'll recall, last spring we had a lot of conversation in the innovation work group about the development of performance guarantees, updating requirements in our contracts and fees at risk associated with reporting requirements. And we have completed that work for the upcoming contract year. OEBB contracts are well on their way to being signed and will be all set by the end of the month before the 10/1 start of the next plan year. And PEBB contracts are soon to follow. We, of course, have a little bit longer to finalize PEBB contracts, being that the contract year doesn't start till January 1st. But the performance guarantees that I'll describe today are final, and so will be consistent in both PEBB and OEBB contracts. So in terms of status, just to recap, the guarantees place 15% of medical carriers' total administrative fees at risk. And that 15% is divided across 3 specific areas of performance: 5% for administrative performance, 5% for clinical quality, and 5% for performance on financial trend. We have also incorporated some additional reporting requirements without fees at risk. And these requirements have been established for account management, clinical management, and transparency. Next slide, please. So just providing a little bit more detail on the administrative performance measures. These should look fairly familiar as in our last update back in June. These were near final at that time. You can see we have 9 specific measures that relate to carrier administrative performance with targets established for each. You'll see on the last measure, that is a newer measure that we have not worked with our carriers on before, the claims auto adjudication rate. So there is not a firm target established for that measure. Rather, it's report only in year 1, meaning that essentially carriers, as long as they report their rate, that will count as complete for meeting that measure. And as staff, we anticipate taking a look at that, having some discussion with the carriers, and considering a specific target for that measure in a future year. In terms of the scoring, it's a pretty straightforward scoring process. Each of the 9 measures is worth 1 point if the target is met. And carriers have to achieve 7 points or greater to retain 100% of fees at risk. 4 to 6 points will be a 50-50 split of the fees at risk between OEBB or PEBB and the carrier. And if a carrier achieves 3 points or lower on these administrative performance measures, that is 100% of the fees at risk returned to OEBB and PEBB. Are there any questions about these measures? Great. Next slide, please. Our clinical quality measures for the next contract year are a slightly larger set. These include the 15 measures listed on this slide. As you can see, 13 of them are specifically related to clinical care delivery, and then the last two are CAPS measures from the Consumer Assessment of Health Plans survey. They're survey measures, member responses to particular survey questions on the overall satisfaction with the health plan and getting needed care. And Tom, it looks like you have a question.
Yeah, I know that, for an example, number 7, statin therapy for diabetics, I'm sure that the Health Plan Quality Metrics Committee approved that. I don't remember whether or not we did adherence. So my hope is that you've looked at all of these and they're all on the list.
Yes.
Thank you. That's all.
And we're definitely continuing to every year, I mean, to track what the Health Plan Quality Metrics Committee, how the measures are evolving and what work is going on there. I think, there is the balance between we overall want to have a consistent and stable measure set, but at the same time, we want to have a measure set that has room to evolve with evolution and what the HPQMC develops. So we are working on that balance, but yes, in terms of the measures for next year.
The additional point there is OEBB and PEBB have 2 representatives on that committee, Sean and myself, and anything that OEBB and PEBB want to move forward, we will bring it forward to the committee and make sure that it gets accepted. So it goes both directions. We're not just responsive to to that committee. We can direct the committee on things that work for us. So the only thing is it'll have to fit into their time frame. That's all. All that because you used to run it. So.
Yeah, absolutely. And thanks for noting that too. Yeah, I mean, I think that is absolutely with you and Sean both serving on that committee, we are active participants in the work of that committee. And absolutely, I think it is sort of 360-degree collaboration in terms of us also providing feedback in what we're seeing in our programs to the committee in considering quality measurement. In terms of the targets for the clinical quality measures, we have set targets at based on the HEDIS national percentiles established by NCQA for these measures. And those are based on all commercial plans reporting nationally. We've set those targets at the 66.67th percentile, the 75th percentile, and the 90th percentile. And in terms of scoring, you can see on the slide, carriers will get 1 point for reaching that 66.67th percentile, 2 points for achieving the 75th, and 3 points for achieving the 90th percentile. Next slide, please. A little bit more about scoring and how the carriers will be compared to those percentiles. So HMO plans will be compared to the national commercial HMO percentiles, and CCM and PPO plans will both be compared to the national commercial PPO percentiles. However, we did want to incorporate a way to differentiate CCM plan from PPO plan performance. So although the CCM plans will be compared to those PPO percentiles, they do have a higher score required to retain the fees at risk due to the expectation that there is some improved quality relative to PPOs. So even though we're using that same PPO percentile to basically rate the CCM plans, we do have a slightly higher threshold in the scoring for CCM. And you can see that described in the table below. So for both the HMO and PPO plans, and the HMO percentiles run higher on performance than the PPO percentiles. But both those HMO and PPO plans will have to have 19 points or higher to retain 100% of fees at risk. For the corridor of 14 to 18 points, it'll be a 50-50 split. And then 13 points or lower will revert 100% of fees at risk to OEBB-PEBB. And if I could ask, it sounds like someone might have their microphone on. If I could ask you to please mute, that would be helpful to make sure that everyone can hear the conversation. And then for the CCM plans, as I mentioned, their point threshold will be a little bit higher on that PPO scale, the PPO percentile comparison. So it's 21 points or higher for the carrier to retain 100% of fees at risk. The 16 to 20 point corridor will be the 50-50 split. And then if it's 15 points or lower, 100% of the fees at risk return to OEB and PEBB. Next slide, please. On the financial trend rate guarantee, this is established to require total cost of care per member increases at 3.4% or less. So if a plan's cost of care or the plan's cost increase 3.4% or less, they have no fees at risk, essentially no penalty. If the increase is between 3.4% and 4.0%, a penalty of 2.5% of total administrative fees will apply. And if the increase is over 4%, then the full penalty of 5% of total administrative fees applies. So the baseline year for this guarantee is the plan year beginning, or it's rather the baseline year is the plan year ending. It's this plan year that's just ending for OEB. So the plan year ending 9/30/21 for OEB, and the year ending December 31st of 21 for PEBB. And then the initial measurement year that's going to be compared to that baseline year is the plan year that begins just the upcoming plan year for OEB, which is the 10/1 plan year start, and for PEBB it'll be the January 1st of 2022 plan year start. Next slide, please. Oh, Tom, you have a question?
Yeah, just I assume, for OEB, MODA has 5 different plans. Kaiser Permanente has several, 3. I assume those get all added together, an average for each of the carriers.
Yeah, so it's a guarantee. It's a consolidated guarantee essentially under the carrier contract for OEB. So so for Kaiser, it's a single guarantee for all enrollees, all OEB enrollees and Kaiser plans combined. Likewise for MODA. I should note for PEBB that it is actually done separately for Providence Statewide and Providence Choice. Those are 2 significantly different plan arrangements that PEBB has with Providence, with significantly different administrative fees for statewide versus choice. And so for the Providence contract, it is a separate guarantee for those 2 plans for PEBB members.
Thanks.
No problem. A little bit more detail about the financial trend rate guarantee. And I know, I think Emery Chen from Mercer is on the phone. So if there are any questions that get too detailed here, I may pull him in to share expertise, but just at a very high level, some of the specifics. No adjustments are going to be made for new pharmacy drugs, specialty medications, or procedures. Pharmacy rebates will be used to offset allowed costs, and the claims base will be adjusted for any plan changes the board adopts, meaning that if there are benefits eliminated in a future year, they would be removed from the base year, and any benefits that are added in a measurement year, any benefits added new in a measurement year would be removed for comparison to the baseline. There are no adjustments for cost sharing changes because this guarantee is based on allowed costs, so those don't play in. There is a large claimant adjustment, so with a $500,000 threshold. So for large claimants, anything above the $500,000 threshold is taken out. There are also adjustments that will be made in the event that new groups join PEBB or OEB. So for new groups of 500 or more members joining PEBB or OEB during a measurement year, there'll be adjustments made to account for that. And then risk adjustment will be applied to offset changes in risk mix due to members joining or leaving the plan. Next slide. So those 3 reports reporting categories really summarize the areas where we have fees at risk in our contract. The next 3 I'll talk about pretty briefly are just additional reporting we've added that don't include fees at risk, but do include various measures that we'll be monitoring with our carriers. So one of those is around account management performance. And for account management, we essentially have the 6 categories listed, 6 measurement categories listed related to carrier performance on management of PEBB and OEBB accounts. And the target we're aiming for is at least 3 out of 5 on the score for all measures. And you can see the scoring key where 1 is equivalent to consistently does not meet expectations, and 5 is equivalent to substantially exceeds expectations. Our plan is that this rating survey for each carrier will be completed twice annually, generally in the post-renewal and also the post-open enrollment timeframe. So we're looking around, May and November each year. And it'll be completed by board leadership and PEBB and OEBB staff working directly with the carriers. We'll aggregate the results, and then we will use those as a tool to provide kind of more specific and direct feedback to our carrier partners about OEBB and PEBB satisfaction with account management. Are there any questions about that? Great. Next slide. We also added additional reporting around clinical management, and you can see we have measures listed and targets. We've kind of set these targets, even though we don't have fees at risk at that associated with the targets. These are sort of just targets we're currently comparing against in terms of what carriers will report. The purpose of the clinical management reporting is to get more consistent and aligned information across carriers about just how things are going within the clinical management programs in these particular areas. And our intention is that performance guarantees on these measures may be established in future contract years. For the upcoming year report only, however. And then next slide. And our last, oh yeah.
Tom, this is Tom again.
Yeah. Hey, Tom.
So going back one slide, there's one like around clinical management. I don't know whether or not that falls into the purview of the HQ, the health plan quality. Yeah. Not sure if it does. That staff needs to think about that, because if it is something, that would be one that Sean and I would need to take to the committee.
Okay, yeah, certainly. And that is certainly something we'll be working through in the coming year. Right now, because none of these are incentivized.
Right,
and we're really
I know it's not an issue.
Yeah, but
it takes us a year. It takes us a year to get it on. And
certainly.
And I don't know, it's possible that they're not viewed as clinical quality, but I think at the first one, actively managed members satisfied with case management programs, that's kind of on the cusp.
Okay. Yeah, certainly. We can absolutely look into that. For some of them that are more process focused, like the timeliness of reviews or something, I would.
That's not an issue.
But certainly.
Maybe number 1 and number 2.
Certainly. Yeah, point taken. We'll definitely take a closer look at that. Yeah.
Thank you.
Yeah, thank you. And then looking ahead to, I think this is our last slide on the reporting. So our last category of additional reporting we've incorporated is around transparency. And there are 3 kind of discrete categories of reporting in this section. One is around level of payment. And this is reporting we'll be requiring annually from carriers, providing their payment rates relative to Medicare rates across specified provider types and service categories. This is similar to data that the Innovation Workgroup has requested before from carriers, and carriers have provided. We're incorporating it into the contract as sort of a standard annual reporting requirement. The second category is increase in payment or payment variation, and the reporting requirements here align with new federal transparency and coverage regulations that essentially require public reporting of pricing information. And so our goal here is to capture this transparency and coverage in pricing information annually from our carriers, as it'll permit us to do some additional analyses and comparison within the data in looking at our programs. And then the last category is value-based and quality-related payments. And this is an annual reporting requirement around dollars associated with value-based payments in categories that we've established in contract. Are there any questions about this slide or any of the previous information included in this deck?
Yeah, Margaret,
Yeah.
Jeff, we've been at this for a while, which is to be expected.
Mm-hmm.
In aggregate, are there really any new measurements, or is there just a better alignment?
For across PEB, well, there's definitely better alignment across PEB and OEBB contracts and across our contracts across carriers. There are some new measurement, definitely. I mean, for example, the financial trend guarantee is something new. We have never, we've had on the PEB side, we have had guarantees associated with financial trend in some of our contracts. They haven't been exactly of this sort of trend guarantee. They've been a little different.
Okay.
But for a lot of our contracts, it's new. That is a new piece that we have not incorporated. Additionally, I think the account management survey is another example of something that's new, where we are doing kind of a systematic review every year of account management and providing that consistent, systematic feedback to carriers. I think it's just, it's from a process standpoint, it's something new for us to be doing, to have that sort of two-way communication.
So in the majority, it's really an changes in weighting and what the penalties are with alignment. And what I'm getting at is we haven't really asked for much more of an administrative burden, so it should not be reflected in the administration costs going forward.
Yeah, I would expect not. I mean, the reporting we've requested is certainly generally consistent where carriers are reporting for the clinical measures, the administrative measures. Those are areas they've reported on before. The trend guarantee, even though that is a new performance guarantee with dollars at risk, that is something that the consultants and our actuaries will be doing the analytics on. So it doesn't really create a reporting burden for the carrier in that respect. So some new reporting and some new areas, but hopefully not significant additional administrative burden.
Okay, thanks for kind of refreshing me on some issues.
Yeah, absolutely. Thanks for the question.
Any other questions before we move on?
Hey, Margaret, it's Michael. I just wanted to make a couple comments. Some of the reporting that you metrics are standard in the industry, and are, like, for example, in accreditation standards. Excuse me. So, and to Jeff's question around whether this provides results in administrative burden, these are really common metrics that other self-funded plans routinely ask for. So, and then the HEDIS, of course, are standard for plans that are accredited. So I just wanted to make that comment.
Yeah, thank you. Yeah, as well, Michael. Though, we tried to, as best we could, align with reporting that was already happening in other areas for health plans.
So, Margaret, you will not be surprised to know that I'm excited and interested in the transparency reporting here on the screen. Particularly, I mean, they're all important, but I'm curious. I have follow-up questions about what number 2 may look like. This is probably not the time, but there's just a lot of ground that covers, and I'm curious as to what that may end up looking like. And so, anyways, maybe it's a future topic or something I can just hold on to until we have some examples. But
yeah, well, a couple of thoughts there. And my understanding is that so the federal regulations or requirements around that reporting are still I think somewhat unfolding. And so our contract language does specify that that reporting will be consistent with federal requirements. And I don't want to put Emery on the spot, but I don't know if he has maybe a 30 seconds wants to chime in with some of his thoughts in response to your question in terms of what that data might be, might reveal.
Yeah, sure. Thanks, Margaret. So Sean, in terms of your questions, I think a lot of the things that you have brought up in the past in terms of payment variation, I think we would want to take a look at that and try to review the data as much as possible in terms of how much payment variation there is by the location, whether it's owned by a certain facility and things like that, because that information, all of the allowed charges should be there based on the specific provider. So we should be able to mine that to take a look at a lot more closely and look at payment variations as well. And I think it will also help us take a look at PEBB and OEBB trends and the underlying cost trends a little bit more closely as well, having all of that data being the different claims for the organizations and the providers, and just more detailed cuts. Some of the stuff that we more detailed cuts. And I mean, if your mind is going to certain areas, I think definitely welcome those, and setting up a game plan for actually creating reports and looking at those.
Okay, we can talk about it later. I just know on the PEB board, questions come up repeatedly from some of the board members, like, what do some of these contracts say, between the plans and provider networks? Because we get the allowed amounts and whatever, but oftentimes we don't have insight into literally what the contracts say, and so and what those arrangements are. So it's interesting to think about that. And I also think that there were some transparency legislation in the last round, if I'm not mistaken, which might fit in here too. So it's kind of a bucket of topic that is, I look forward to more discussion.
Yeah, and I'm not sure that the contract would be available in the transparency. I think we're just talking about pure allowed charges, and the actual contracting between the providers and the insurance companies I don't believe is included in this. So I don't think we'll be able to answer that question, unfortunately.
And Sean, this is Ollie. I do know there's a lot of support in OHA around the transparency guarantees. So I think there's a lot of people that are excited to see.
Yeah, maybe there's opportunity to put our heads together with some of those folks. So just like, what are they hoping to see, just to be sure that we actually get that.
Right.
So.
Sean, it's James. Because we are leveraging the federal transparency requirements, there's going to be a really robust data set. So it's actually nice for us that we didn't have to have another data query or another data spec to put out there. But really, it's the filters or the lenses we want to look at this data with. So I think as creative as we want to be, it's going to be a pretty robust, pretty granular data set. And if we want to look at old topics like site neutral payments or just payment variation, it's all there. If we want to take a behavioral health lens and look at behavioral health providers and payments, that's there too.
Thanks, James. And yes. Thanks, everybody.
Okay. Well, I think it's time for us to move on to the Centers of Excellence report.
Okay, hello everybody. Let's see, Margaret, did you want to say anything to kick this off, or do you want me to just launch forward?
I think just, 10 seconds or less. I think we've been working with our carrier partners on program development for Centers of Excellence model. Work has been proceeding along. progress is happening. I think Jenny will get a little bit more into the details of where things stand. And I think we're generally so far on track to have a lot more for this work group to look at later this fall. And I think with that, Jenny, certainly dive into the details.
Sure. Well, it's been a little while since we've talked about our COE and our Centers of Excellence initiative. So we did think it would be a good idea to just give you a quick refresh on where we have been, what we've been doing over the summer, and then what our next steps are. So just a couple slides here to go through just to remind everybody what we're doing. So if you remember all the way back to February and meetings prior to that, we've been exploring the opportunity related to using centers of excellence or developing centers of excellence for the members who are going to have procedures done for things like hip and knee replacements, spine and back surgeries, musculoskeletal types of procedures, because those procedures kind of lend themselves to a center of excellence approach. So after going through sort of a formal RFI where we looked at what vendors could do in this space, at the February meeting, the innovation work group really decided that we'd like to pursue a more customized Oregon-centric approach using our carriers to develop that center of excellence approach for those procedures, and kind of gave their blessing to go forward, as long as each of the OEBB board and PEBB board also agreed, which we did talk to each of the boards, and they said, yep, we want to move forward with that. So that's really what this program is. It's all about driving folks to higher quality providers and facilities. It's all about looking for improved outcomes on those procedures for OEBB and PEBB members. We also want to make sure that the carriers are identifying members early on for this program and promoting conservative therapies before moving on to surgery. And then at the end of the day, we also want to make sure that there's consistency in reimbursement. So the ideal is to have a bundled payment and warranty should we get there. So that's really kind of what we set out to do. So on the next slide, just kind of, these are the rules of the road and who's sort of responsible for what in this particular approach, because it is a little bit different than just using a vendor to identify those. And we talked about this with the carriers in our kickoff meeting, and I'll talk about that in a minute. But this sort of outlines who's responsible for doing what in this center of excellence. So the carrier partners really are responsible for identifying the facilities and providers that they're going to be proposing to be in the COE network. They're going to be responsible for monitoring the facility and surgeon performance going forward, providing member support in terms of that early identification, decision support, promoting the conservative therapies, doing the reporting, and then at the end of the day, negotiating that bundled payment and warranty with the provider. So that's what we identified early on as the carrier responsibilities. What Innovation Work Group and Margaret, what we've been doing is making sure that the carriers are using aligned metrics for quality, so that, if, for example, Providence puts forth a facility to be the COE, and it's based on X, Y, and Z criteria, we really want to make sure that when MOTA, proposes their facilities, that it's based on the same type of information. So our goal is to make sure the quality metrics are aligned and are in line with best practices. Our job is also to compare the carriers' collected quality data with external quality data sources. We'll also be looking for to ensure health equity in terms of the program design and strategy and incentives and all of that going forward. We'll be providing updates to the innovation work group and also making sure there's alignment in the bundle and warranty. So that's our job here collectively to, with this group. And then OEB and PEBB boards individually have some responsibilities as well. So they'll be approving or refining recommendations made by the innovation work group. At the end of the day, they'll be looking to evaluate the incentive plan design and any travel benefit, especially where it makes sense to differ between what OEB might want to do and PEBB might want to do. And then, of course, to evaluate the impact to members, which may be similar or different depending on the population, and make sure they're aware of what's happening in terms of member outreach and education. So I think after this, I'm just going to go into a little bit more detail about what we've been up to, but I don't know if there's any questions so far. Okay, let's move forward. So as Margaret mentioned, we have been pretty busy with this initiative. So mentioned the February meeting where we got approval, March and April where we went to each of the separate boards to let them know about what we wanted to do and get their okay to move forward. In May, we had a formal kickoff meeting with all of the carriers to review the roles and responsibilities that I just went over, sort of the goal of the program, the timeline. We identified the specific MSK conditions or procedures to be included. And that just meant identifying things like ICD-9 codes and DRGs and all that good fun technical stuff. And then we also talked about the volume thresholds that we wanted to identify. So that means, you know, in order for a facility to really be ready to be a center of excellence, they should have demonstrated that they can do, or that they have done a certain minimum number of these procedures over the last 3 years. So in June, really Margaret led this initiative to work with the all payer, all claims database to get some discharge data on Oregon specific claims, to identify those thresholds, or to identify the volume numbers for each of the hospitals or facilities in Oregon. Kind of went through a process of identifying that and communicating that with the carriers. Then in June, we kind of got some feedback from the carriers on the quality metrics to be used. We took a look at the early volume data, had some conversations about that, identified, you know, the facilities throughout Oregon that looked like they would meet those volume numbers, at least based on the data that we got from the APAC team. So in July, just digging in a little bit deeper and kind of identified at least 40 facilities that met the volume thresholds and 30 that met the spine volume thresholds. So the next step really is to dig into the quality piece. So of those that met the minimum number of procedures that they performed, which ones of them are meeting the quality metrics? So we've just been having quite a good discussion about quality metrics. We do have some quality metrics from a database that we use called Quantros, but we talked with the carriers about collecting data directly from the facility on things like, you know, infection rates, revision rates, complication rates, accreditations, etc., just to kind of do an additional check for quality. Our goal is to be as inclusive as possible with the facilities and not necessarily to narrow things down to just 1 or 2 facilities, because if they're all meeting the quality and volume thresholds, they really all deserve to be considered. So that's where we are at this point now. We just had finalized this very specific quality metrics and gave a template to each of the carriers. The carriers have gone out to each of the facilities that were identified and have been requesting this quality data. And, you know, the responses from the facilities are really due back at the end of this week. We've heard from, you know, some of the folks on the MODA team and the Providence team that, you know, given what's happening with the pandemic, some of the facilities have asked for a little bit more time to get the information back to the carriers. So we're still, working with them on that. Kaiser should be able to get the facility information. We did ask for information on specific surgeons that were going to be also affiliated, and that may take Kaiser a little bit longer to do. But at the end of the day, the purpose of collecting this is really just as an additional data point for consideration. If we can't get that back, we can certainly lean a little bit more heavily on the Quantros data. We're also exploring using some claims data from the all payer, all claims database in terms of, infection rates and revisions and that kind of thing. That's going to take a little bit longer to gather. Okay, so that's where we've been. The next step that we've talked with the carriers about is that we're really going to be asking them to, or we have asked them to provide their formal proposals for network supported by the quality data.
Jenny?
Yeah.
I'm sorry to jump in.
Yeah.
I was surprised when you found 40 facilities meeting the knee and hip volumes. It seemed like the numbers, you must have had a pretty low threshold. So what was that threshold? And
Yeah, it's 100 procedures.
100 procedures in a year?
For each, in 12 months, yep.
In 12 months, okay. And the only other group that did the Centers of Excellence from a regional standpoint that I know of is CalPERS. And do you know what their volume threshold was?
Well, actually I'm aware of several different employers who have done either regional or specialized centers of excellence strategies in certain areas. And I'm not real familiar with CalPERS's specific metrics, but the 100 procedures is pretty standard.
Yeah, it just seems like there's 52 hospitals in the state, and I don't know how many. I assume an outpatient surgical center has its own measurement here, so maybe there's 80 entities. So having half of them meet the volume threshold, I was surprised by that. That's all.
Yep.
So Tom, adding on to that, what would you have expected to be the number?
More like 20, maybe 15 to 20.
Procedures a year?
No. I'm sorry. Facilities.
I'm sorry.
Yeah. 100 a year is 8 a month. And that's 2 a week. And you have a team in place when you're doing probably 8 a week. So my guess is that the number is 4 times that.
Okay.
It might be 2.5 times it, but just when you look at the numbers, that's you don't build a team. Remember, it's all the ancillary stuff that goes along with this. It's not just the surgeon. It's having the again, everybody knowing what you're doing, and so my estimate was that it would be more like 250.
Okay, thank you, Jenny. The response that you got, did they respond based on the number that they do, or did they say yes, we do more than 100?
So the initial volume thresholds came from the all payer, all claims, or the team that looked at discharge data. So they looked at discharges all throughout Oregon, all payers, all employers, just everybody who's in that list. Part of the data request that's going to the facilities, or that's in their hands right now, is questions about volume. How many of these have you done, to verify that exact number?
So I would be curious to know the number that do at least 250. Searching for that magical number is also balancing an adequate number for access. I know JJ at our last meeting strongly suggested that we needed to have pretty good regional access. I think that's what you intended to communicate, JJ, for a program like this. So finding that balance, it's going to be a bit of, I don't know whether to call it artwork or what, but finding the balance is a goal.
Exactly. I would agree with that. The volume and the quality, that's the other piece.
Yeah, and the ability so that we're not asking everybody to go to Portland, basically, to state it in the extreme.
And then we'll see also that linkage between cost and quality.
Yeah.
Yeah.
Okay.
Okay. So just kind of
keep it on.
Yeah, just to move a little bit forward. Again, we've asked the carriers, assuming that they'll get the quality data back from the facilities in time, and they have a chance to actually work with each other to share some of that data, because there are some instances where, for example, multiple carriers, both Providence and Kaiser were interested in approaching some of the same facilities like Salem Health, but rather than having each of them issue their own data request, it's like one carrier was nominated to do that or volunteered to do that. So they'll need some time to share some of the results with each other. But at the end of the day, the request is that they provide their proposed COE networks, program, give us some information about the support services and the member concierge services that we expect back to us at the end of October. And then we'll take that information, review it, make sure it's consistent, have a little bit of discussion with the carriers, and then present to the innovation work group the preliminary proposals at the November meeting. And then you can kind of see on the next page what sort of comes after that, and that's going to be refined, So I don't know if Rose, you want to go to the next page? Yeah, so what comes after that November meeting is additional refinement, taking a look at the incentive designs to help, steer members to the program, and then start presenting the ideas at the individual boards during the renewal cycle for consideration. So that's really, I think, where we are and where we're headed. That's, I think, my update, unless anybody else has any additional questions.
Jenny, I don't have it right in front of me, but there was a graph that looked at, I think, knees and hips that had numbers and average cost per case. Is that farther down in the packet?
No, we did look at the variation in cost per procedure a little while ago, but that was before the implementation of the hospital reimbursement.
Yeah, I'm okay, fine. Thank you.
Yep.
I remember now. It's under the hospital discussion.
Maybe in the appendix. I mean, at the end of the day,
it's in there. We'll get to it when we talk about the hospital 200% of Medicare.
Gotcha.
I had another issue. Sorry.
Emery's report, yes.
Okay, thank you, Jenny.
You're welcome.
Next up is the behavioral health network analysis. Is that Wendy or is it somebody else?
That is Cindy and Dan.
Cindy, excuse me. I keep trying to call you something else.
I know, and I find it delightful.
Oh. Hard to teach an old dog new tricks.
No need to. You are right just the way you are.
Thank you.
So for a refresher for the folks that are on this call, you may recall that when we put out Lodestar 2.0, one of the key areas of focus and ripe for potential innovation and improvement was around behavioral health. And at the time, we knew that we didn't have a lot of information about behavioral health network adequacy as a whole and how members did or may not be able to access services. So part of the work that we proposed to do over the summer was to look at behavioral health adequacy with the carriers and EAPs. And I'm very happy to present the summary of our findings of that work with my colleague, Dan Wendt. Who is, I always say you're a licensed clinical social worker, but you're a licensed social worker, right, Dan?
Yeah, licensed master's level social worker, Cindy.
Thank you. You're both. So I'm going to kick things off, and then Dan's going to help with some of the findings that we had from the carrier component. What we will be covering today is giving a little bit of background, a little bit of context as to the behavioral health, specifically the behavioral health healthcare landscape. Give a little bit of information on provider network management, what that is, and how carriers and EAPs typically manage their networks. Talk through some national best practices so you can be aligned with what we were comparing some of the findings to. And a little bit of a summary of the differences in the roles between carriers and EAPs when it comes to behavioral health network. We will then give you a brief overview of the behavioral health gap analysis process that we went through, and then provide a summary of findings. The behavioral health topic area is a pretty broad topic area. So we also have included a lot of information in the appendix. For one, you will find the behavioral health gap analysis questionnaires that we sent to the carriers and the EAPs, but we've also included some supportive information on behavioral health. Key terms that are used when talking about behavioral health services, and there's some information on the array of behavioral health services that are typically part of a adequate network, in case those are reference materials that are helpful for folks on the call. Next slide, Rose. So there's a lot actually happening nationally, but in Oregon in particular around behavioral health and particularly around workforce development. The OHA and the Office of Rural Health have a healthcare provider incentive program where they are providing loan repayments for behavioral health clinicians seeking licensure. And a lot of that work was based off of a report that showed that people of color were representing about 13% of licensed behavioral health professionals. Again, Oregon is not unique here, unfortunately. This is a national issue with behavioral health provider shortages, but that's one initiative that Oregon specifically is utilizing to tackle this. What else is interesting is that this issue is really at the highest levels of government within Oregon. In the 2021-2023 governor's budget, there are two different initiatives that are proposed in that budget with some significant investments to build behavioral health workforce diversification so that behavioral health and really medical workforce as well are adequate and representative of the community served. And then investments in behavioral health services. So in substance use disorder treatment more specifically, but there's some other broad behavioral health initiatives within that budget. So I feel like when we're, as this group, looking at this as an issue, we're in good company. This is not an issue that we alone are looking at. Next slide. So what is network management? When we talk about how carriers manage a network, what is the process that they go through to build a network? Essentially, it's a 6-step process where you're identifying the needs that you have using a gap assessment, or identifying the needs of the members, or really looking at what services you are contracted to provide to members, and then making sure that you have providers available and taking new patients to support those service needs. They then go out and recruit providers in the community through outreach endeavors. They most typically at carriers have staff for this that go out into the community and are engaging providers in associations or by knocking on office doors. They then will contract with that provider. This is the point where fee schedules and reimbursement rates are negotiated with the provider. That provider would then go live with that carrier and be introduced into their provider directory, and they might have some training and onboarding in order to interface with the carrier. Then there's ongoing quality management. There's supportive and monitoring activities that carriers do to make sure that they don't have a provider who, for example, has criminal charges against them and shouldn't be serving the public. And they're also looking at the quality from a quality metrics perspective, and some carriers may even use that quality information to rate providers. And then there's just ongoing continuous improvement with all of these areas. Next slide, please, Rose. So when we were looking at how to understand the quality of network adequacy and network management with the carriers and EAPs, we really had to look at what were the elements of a strong behavioral health network. And really the components that we found that are national best practices and also practices of many of the participants in this program are: one, you have to have an adequate choice of providers. An adequate network really means that there's not just one provider for the service that I need. If I don't like that provider, or for some reason that provider and I don't partner well together, I at least have a choice of providers in my area. That the full continuum of behavioral health services is available in network. So any of the behavioral health services that are part of my benefit, I should be able to get access to those services, and those services be in network, or at least available to me in network, and I make a decision to go out of network. That I can get to that care timely, that when I need those services, there's a timely access for me to get to those services. Accurate and up-to-date provider directories. Members sometimes self-serve, and provider directories can even be used by other providers to find services. So accuracy and making sure that that information is up to date is a critical component. Culturally competent care, I would put under this umbrella diversity of practitioner, so that there's someone that looks like me that can potentially serve me. Integration of primary care and behavioral health care is a national trend, that moving behavioral health practitioners into primary care practices and vice versa. So having primary care practitioners be present in behavioral health provider practices. And then finally, evaluating and rewarding provider quality. I think when we start talking about value-based purchasing components and identifying quality providers within a network, having a standard to evaluate and reward provider quality becomes even more important. And those were the elements that we were specifically looking for to sort of as the measuring stick, so to speak, for the work that we were doing in the gap analysis. Next slide. So what are the different roles and responsibilities? I think it's important for us to know that what the carriers do and the EAPs do is different. EAPs, for example, conduct assessments and referrals for identified problems, but this is short-term problem solving and brief counseling. Someone calls the EAP with an issue. They are either doing some short-term interventions from a behavioral health perspective, or they're identifying that this is not a brief intervention and we need to get you to a provider. The carriers, on the other hand, they contract with an array of network providers. and in some cases may even own the providers that are in their network. They have to ensure that there's adequate access across the full continuum of behavioral health services, ongoing monitoring of network access, so doing evaluations periodically during the year to make sure that the network remains adequate given the different parameters and needs of the membership. They credential in-network providers, so they make sure that the credentials that a provider says they have are actually the credentials that they have, and they're not serving the public without a license. And they implement processes to contract with out-of-network providers when necessary for members to obtain services that might be needed outside of the network. Next slide, Rose. So what was our process? We took a 4-step process to complete the gap analysis. Our first step was to send a questionnaire to each of the 3 carriers and the 2 EAPs. They submitted their responses and our team evaluated those submissions, compared them against the national best practices, and then we built this presentation to share those findings with you. I will say that, and it's a disclaimer that's on this slide, but what we did truly can't be considered an audit or any sort of compliance analysis. The contract requirements around network adequacy currently are rather silent. So we were, in fact, comparing against national best practices and promising practices to give you a flavor of the performance and where the behavioral health networks stand today. Next slide. The questionnaire, and you have each of the questionnaires in the appendix if you're really curious about the actual list of questions, but essentially it fell into 5 domains. We asked questions around access and availability. So these are things like prior authorization practices. What services, behavioral health services, do you require prior authorization? What are your contracting practices? Do you set minimum adequacy standards, and how often, and what's your process for use of single case agreements? Single case agreements is a term that's used when you are doing a contract with an out-of-network provider for a short time. We looked at enrollee satisfaction, so we asked about member satisfaction surveys. We looked at denials and appeals and member complaints. We asked about quality, how they evaluate quality of behavioral health services, and asked for some recent performance results if they had those available. We asked questions around the provider directory, what type of information is part of the directory, how often is it updated? Do they include things like race, ethnicity, and gender? And do they also include on the provider directory if the provider is accepting new patients? And we looked at provider support and satisfaction as well. Do they have dedicated behavioral health support network staff? Is there reporting, and do they evaluate provider claims, disputes, and provider complaints when they are having issues with the carrier? Next slide, please. And I'm going to turn things over to Dan, because I think you're probably the most interested in what did we find when we got these responses back.
Great, thanks, Cindy, and thanks to the work group for the opportunity to present our findings on the Behavioral Health Network gap analysis. Rose, if you could go to the next slide, please. So just a quick note about how we organized our findings, both for the carriers, and then we have some slides for the EAPs that will follow here. But we essentially identified which elements were included, and then based on those elements, we summarized the most relevant findings from the information that was provided. We went through that information and tried to identify where we saw what might be considered promising practices or practices that align with industry standards. And then for many of these, we were able to identify some potential opportunities for you all to consider for future next steps. So on this one, we're looking at 3 elements, include what services are prior authorized in terms of behavioral health, the single case agreements that Cindy spoke to earlier, and then the presence of any wait list associated with covered behavioral health services. And when we did note that the services that are subject to prior authorization are pretty standard in the industry, and we don't feel like that should be inhibiting access to any of the covered behavioral health services. We also note that all the carriers are utilizing single case agreements when presented with that that need. We weren't sure if all the carriers are tracking and trending that data. Typically, a health plan or a carrier will track and trend requests for single case agreements to help identify potential gaps across the contracted network, and then approach those providers to see if they're interested in becoming more of a permanent member of the network. We think some of the carriers are using that data like that. We're not sure about some of the others. And then we did note that one of the carriers reported the existence of a wait list for several services that are listed here: therapy, psychiatry, residential substance use, mental health, intensive outpatient. So that for us was somewhat concerning, that a wait list exists for those services. We really are recommending that additional information be gathered about the nature of those wait lists, how many subscribers are impacted, what's the wait time associated with each of the services, what interventions or follow-up actions is the carrier taking to mitigate those and eliminate those wait lists. We also noted some promising practices in terms of one of the carriers has been successful to convert many of the single case agreements over a 12-month period, and they've added over 20 additional providers to their network through that process. Next slide, please. On this one, we're looking at network management and just how are the carriers monitoring ongoing access? Have they established minimum network standards? Do they utilize geospatial mapping or geospatial analysis to identify where their enrolled population resides, and then what the proximity of those behavioral health providers are to the population? One of the things we noted is that when we asked about availability of weekend appointments or after-hour appointments, many of the carriers were able to report out on the status of their network in that regard. They didn't have that information available. There are appointment availability for most of the in-network providers isn't robustly monitored by some of the carriers. And we did note that all the carriers were able to produce at least excerpts of a geospatial mapping analysis. Those are typically done annually. And so we got different reports and excerpts of reports that showed visuals of their mapping or data tables that demonstrate compliance with time and distance standards that they've established. So the positive thing here is that all the carriers have established network standards, and they align with industry practices. The most common network standards we typically see are enrollee to provider ratios, time and distance standards that I mentioned previously, and appointment availability standards. So how much time is allotted before an initial appointment can be made, and then subsequent to that, for ongoing appointments, there's usually a standard for making sure that a follow-up appointment's available within a specified time frame, either 14 days or 30 days. We did identify some potential opportunities here as well. We think that there should be a process to collect and publish data from the provider network about hours of operation. That's typically an element that's included in the provider directory, and we would recommend that be completed. We also, while the minimum network standards have been established, we didn't see a lot of evidence of robust oversight of those standards. One of the carriers, it appears that they mainly just utilize a behavioral health satisfaction survey to assess compliance with their standards. But we think that there's an opportunity there to make that monitoring more robust. Some of the standards are only applied to high volume behavioral health care specialists, and it's unclear how the rest of the network is monitored in terms of access and quality.
So question on that is,
sure.
When we're talking about specialists, I suspect that's probably where most of the wait listing is occurring. Did you verify that, or you have any sense of that?
Yeah, we didn't get too much detail on the wait list, but the services that were identified were all therapy and psychiatric services, so it's pretty broad. Residential substance use, neuropsychiatric, and mental health intensive outpatient treatment. Those were the services that were aligned with the wait list.
Anything else? A lot of services.
Yeah, that was definitely a kind of a surprise. Didn't really expect to see that, and it is concerning that there is an active wait list for covered behavioral health benefits.
You're probably going to be able to get into this, but I mean, is there any comparison with that particular carrier as far as provider rates being offered in that network compared to the others? I mean, are they just not enticing at all to work in that network, or I mean, is that the score?
Yeah, we didn't really get to the root cause of the wait list. We did ask a question about why providers were reticent to join the carriers network, what those reasons were, and reimbursement rates were one of the carriers identified that as a potential barrier. And I think as we get a little bit farther through the findings here, there's some additional information about those perceived barriers to contracting, but we weren't able to kind of drill down to see why does a wait list exist and what the issue is in terms of the challenges associated with having a sufficient network.
Sean, I'll add, one of the ongoing recommendations that we have later in the deck is to potentially look at reimbursement rates across carriers to see what the variation might be, because reimbursement, as Dan said, was a frequently reported issue.
This is Tom. I just emailed Glenn Bailey, who staffs our CIAO group, and we'll spend some time looking at it, at least for OEBB.
And is this the same environment for EAP as well?
As far as wait lists, Ollie?
As far as wait lists, differences in reimbursement rates.
I think the differences were the differences between what we saw with the carrier responses and the EAPs is pretty divergent. There were no wait lists utilized with the EAPs, and they contract a little bit differently because the array of services that they're typically working with are much more truncated than a carrier who has to provide network adequacy for an array of the continuum of behavioral health services. So there were some differences there as well.
This is JJ. Are wait lists fairly common with inpatient substance abuse programs?
I think certainly that's a challenging area, but typically it's been our experience that you really want to avoid the wait list. So again, these are covered benefits individuals should have access to, and the carrier really needs to kind of be able to alleviate any wait list for these covered services. So really don't see a lot of flexibility here in terms of maintaining wait lists.
I mean, that's the ideal state. There are small situations where there simply aren't the right number, there aren't adequate number of people in the at least in the northwestern United States. Example is child psychiatry has been greatly. We don't have enough child psychiatrists, so that's an example where those things happen. But major areas of services, we need to understand what's happening with access to our members. So this is what you're describing is very important, and we need to move forward to understand it to a greater degree.
Was the same carrier that was not tracking their what did you call them?
Single case agreement.
Single case agreements. The same carrier that had wait lists?
I believe that's to be the case, but I'd like to go back to the source data and confirm that, but I think you're right.
There you go.
Okay, if there's no other questions, we still have several slides. I want to keep us moving. Rose, if we can go to the next one, thank you. This is where we looked at choice of behavioral health providers, like within a particular discipline. Do I have a choice as an enrollee? And are the carriers contracting with all available behavioral health providers that might be out there? I'm just going to hit a few of the high points here. One of the carriers reported that choice is available for all outpatient provider types, unless there's a request for bicultural, bilingual providers. Then that became more of a challenge. This was, I thought, really kind of another key finding. One of the carriers reported that many behavioral health providers do not accept new referrals. And they state that when they're trying to assist enrollees to access services, that they have to typically call 10 to 20 outpatient providers before they can find one with an available appointment. And that issue is magnified, obviously, in rural, remote areas. And they also mentioned that provider diversity is an ongoing challenge. So that was a little bit telling finding as well. Okay, here's the information on why providers may not want to contract with a carrier. They identified difference in rates. They were not interested. They were non-responsive. They closed their practice. They had out-of-state relocations. They were unable to complete the credentialing requirements due to expired license or adverse action on their license, or they were just non-responsive in providing the necessary documentation for verification. That carrier identified those issues as reasons why providers refused to contract with them. Just based on the responses and the information for these areas, and I think this isn't news to you all based on one of the earlier slides, but it suggests a larger behavioral health workforce issue in the state, and may necessitate the need to explore other options for identifying resources. It looks like definitely the pandemic resulted in a lot more providers providing services through telemedicine, and to continue to leverage that. In one state that I've worked in, They utilized primary care providers to treat uncomplicated mental health conditions like uncomplicated depression, anxiety, or even ADHD as a kind of an additional workforce available that could prescribe medications. Working with the local National Alliance on Mental Illness to identify other providers and resources that are in the region, or even partnering with educational institutions to access medical interns that can help support and provide services. So there looks like there is a broader workforce challenge just based on some of the information that we collected from all the carriers.
Excuse me, but unfortunately, I have an issue here at home that I need to attend to, but I wanted to add some things, and pardon me if I'm a little bit ahead of where you are. But I did some additional research on the web. So, it's the web. But in terms of overall providers, we seem to be about 25% short of the needed providers in the United States as a whole. And when I looked at certain regions, one report divided the US into 9 regions. We actually were 3rd highest, although we are lumped in with California, so that could skew things quite a bit. The projection of needed professionals, which includes marriage and family, psychiatrists, mental health counselors, social workers, psychologists, and school counselors, which is very important to OEBB, is that by 2025, we're going to need just shy of 1 million professionals. And the projected availability is going to be about 3/4 of that. So 25% short, actually. So what's our opportunities to actually solve our shortfall? Because doing more administration is not going to solve that very basic need of access and adequate treatment. And that's the frustrating thing to me is we can ask them to give us more reports, but so what? How do we leverage the providers that we have? Maybe we can ask carriers to expand telehealth to include practitioners from other metropolitan areas that may be more resource rich than we are. But we're not going to get there administratively. We're going to find ways to be able to address the specialties. Waitlisting is most likely a function of just not being available. So to tell them they can't have a wait list isn't going to get us anywhere because there's no providers to eradicate that. That's where I'd like this to go is what kind of innovation can we do to at least stretch what we have, knowing that we can't fully solve this in the next couple of years.
Yeah, I really appreciate that, Jeff. I was going to add something that fits perfectly. So,
Sean, I need to turn the meeting over to you for about 15 minutes.
Sounds good.
Thank you.
Yeah. So it's in my interactions with the behavioral health professional, the field in Oregon, exactly what Jeff just said. There is a general baseline too low of a actual number of people to do this work. Not even getting into the problem of diversity of that workforce. And because of that, the answer as to why the networks are so difficult to staff is fairly straightforward. You have these providers who easily fill their appointment slots without the network, just freelance, and they get reimbursed at whatever they are setting for themselves, essentially. And then you have this network that comes and asks, don't you want to be on our network? And their reimbursement rate is perhaps the same, perhaps a little less and twice as much administrative work. And they're like, why? I have all of my appointments filled without you. Why do I need you? And that's it. It's really not more complicated than that from their point of view. And so to just kind of finish up with Jeff's point, I mean, it feels like we have a pipeline problem of which has to do with reimbursement. And also there's this administrative, like we are competing against basically people that are able to fill their own books without the help of a provider network with way less work. So there's that. JJ?
Yeah, I was just wondering, is there, as an agency, is there something we can do about that? Can we put in some incentives in our contracts for expansion? Can we put in some language to incentivize using H-1B process to get folks from out of the country even to come in? I know one of my employees used to work in healthcare in California, and a lot of the agencies there massively expanded their workforce by bringing in nursing staff from the Philippines, and it was a multi-year program, and they were able to meet a need even though they didn't have local talent. So is there something contractually that OEB or PEBB can put in place to incentivize that kind of behavior to expand their network capabilities?
And just to piggyback on what JJ said, is there a capacity with EAP to expand, services, or maybe there's different scopes of services by EAP? That's an area that doesn't count against our 3.4% that we could actually maybe invest in, pay a higher rate, I don't know, and help with some of the backlog. Whereas, our medical plans does count against our 3.4% cap, so it's a little bit more restrictive. Just a comment.
Tom, did you want to add something?
Yeah, in the short term, I think that the expansion is going to need to be is making sure that our primary care clinicians have the connection with the behavioral health staff, so that when they do go on and take on some of the issues, the uncomplicated depression and anxiety, etc., that they have the backup that allows them to do it. Actually the obvious answer is that you have people, we have a 25% shortage. You ask people to talk 25% faster, so you're able to kind of get it done in 25% less time. But if that doesn't work, then it's things like you can't fill the pipeline quick enough to solve this problem. I don't think there is that out, even, as JJ talked about, nursing staff has been pretty mobile. For behavioral, the subtleties associated with behavioral health is so culture dependent that it would be a challenge to what you're describing. So I think we're going to need to just support all the people who can participate in this. I mean, I just think back to my own days as a primary care doctor. 20% of my schedule, I was dealing with the main issue was behavioral health issues.
Also, one other thing, I know, Tom, you're making a joke about speaking 25% faster. Can we ask folks at the state to use some American Rescue Plan funds to institute some grants for behavioral health agencies to expand their telehealth capacities? Because if we give a grant for technology development, that would qualify under those funds.
You're right on, JJ, and we actually, OEB and PEBB have the data to be able to make that request. As we saw, I think it was a 15% increase in outreach, the request for behavior, because that's the other thing that makes this thing so complex, is that while we have a deficit of behavioral health therapists of every color, both type and ethnicities, language, and all of that, we've had at least a 15% increase in the depression and anxiety and the other underlying conditions that have been fueled by the pandemic. So that what you're describing, and Ollie, this is maybe something that you can run up the OHA process to find whether or not there's that type of option available.
Definitely.
So I want to add one more thing, and then I want to give our presenters a chance to, kind of have an initial response. We've thrown out quite a few ideas. So to summarize, I think what we've been saying is, I think there's some appetite to consider a pretty broad spectrum response to a fairly insurmountable structural problem, which is that there are just not enough total. And we can't just, it's not like a problem with Oregon, although my understanding is that Oregon is actually quite bad compared to neighboring states. But really poaching behavioral health professionals from other states is kind of probably not a great option, although I kind of like JJ's option of maybe other countries. But point is, full spectrum response from recruiting, signing bonuses, expanding the categories and definitions of people that are eligible to do this kind of work in Oregon. The whole thing, middle schools, like the pipeline, everything. But the last thing I would add to that summary is, due to recent legislation, it's my understanding that there will now be a behavioral health committee, legislatively mandated committee, that will include PEBB and OEBB. Tentatively, I've been asked to participate, so we'll have some representation. I have no idea what's going to come of that, but I think the idea is that it's sort of a state level, committee to attempt to think about these broader issues. That all being said, we have a specific job to do here. So let me just pause here and give a chance for some response on some of these ideas.
Well, I certainly appreciate the challenge with the behavioral health workforce issue, and it's not unique to Oregon. It's a national-wide issue, and the commenter that talked about kind of a perfect storm with the pandemic and the increase in need is kind of converging with the lack of resources and making the problem magnified. So. And definitely that might be something that's beyond the control of individual carrier that you're contracting with. I still think that there's some value in developing some standards in your contract, as well as some reporting requirements, so that you have more visibility into what the issues are, and that you can monitor and work collaboratively with the carriers on initiatives and innovative ways to expand the workforce. Definitely maximizing the use of telemedicine beyond your borders is a potential opportunity to access more providers. But there's some real challenges here when you talk about the workforce, and unfortunately I don't have a quick, easy answer for you today. Cindy, I don't know if you've got anything to add there.
Well, I would just add that telehealth and other modalities, digital interfaces, being able to chat with my provider, they're all ways to make an individual provider more efficient. So maybe not talking 25% faster, but making themselves so efficient that they can do the same work with almost the same level of effort that it took to see one member that now it takes maybe to address 3. But Dan's right. These are complex issues with complex solutions that, one, it's not going to be 100% solved by having more of a lens into what your carriers are doing today, but it will help you start to make decisions on the levels of interventions that it's going to take, and it probably will take partnering. For example, there's a real value to bringing maybe not even a fully licensed behavioral health professional into a primary care practice. They may not be the one prescribing the medications, but it's a way to expand the behavioral health capacity within that practice. So it's an innovative way of expanding access in that way. So it will take looking at national trends and best practices to address this issue, and it will take, governmental interventions as well, which I think are happening. But there are ways to actually move the needle forward, even though there are some real constraints that you and the carriers are going to bump up against. Reimbursement rates may mean that I'm not even contracting with the available pool of providers, even if the pool of providers is too small for my membership. So I think there's definitely opportunities.
So we're kind of, you have a question there? Is that JJ?
Yeah, this is something that the experts would know better than me. Will we run into barriers as it relates to licensure for behavioral health specialists if we are dealing with folks outside of the state? And if so, is that something that legislatively or through the governor's office we might be able to address?
It's possible, JJ. I don't think we specifically looked at what Oregon state law says about providers who are not licensed potentially in the state of Oregon. What we do know is there are national behavioral health players that are providing additional support from more of a national perspective through telehealth. And there are health plans and carriers who have contracted with these larger organizations to supplement their behavioral health network with providers that are outside of a state. But I will say we did not specifically look to see if Oregon law allowed that. So I'm just not sure.
So Cindy, this is Michael. I was just going to make a couple comments about that. A couple of things. One is there has been around for some time now a nurse compact for recognition by different states of RNs. That includes LPNs, RNs, and nurse practitioners for licensure across states. Oregon, unfortunately, is not a member of the nursing compact. There's also a more recent medical compact, and I believe all the states are part of the medical compact. And for social work, there's just the beginnings of study about having interstate social work compact agreements. I also just wanted to make another comment, which is nationally, only about 50% of the BH providers are in any insurance network. In some areas, like for example, the Bay Area, only 25% of all the licensed behavioral providers are in any insurance network. And I think one of the recommendations that Dan and Cindy are going to talk about is actually talking to the providers to find out what are the barriers. My suspicion is it's reimbursement. So it may be that it's a multi-pronged strategy around increasing the BH workforce by having more attractive reimbursement rates, and you can couple that with quality management or what have you. Another one would be taking a look at reimbursement for group therapy. So rather than talking faster, having more people in the room to get therapy would be a more efficient way of potentially of treatment, and that can be effective with certain individuals. And there was a mention around expanding EAP. There are some EAPs actually that now offer up to 20 or 30 visits per member per year. That comes at a pretty significant increase in their costs. It exists, but it's a very different, it's almost like a carved out behavioral health network. So anyway, those are just a few comments.
Well, and the EAP is kind of at the lower end of the spectrum, as you reported earlier, moving into more intensive types of treatment. Expanding the primary care givers has some consideration from the standpoint that we have been focusing on integrated systems of care and developing those, with Kaiser, but also with Moda 360. I'm not familiar with what Providence is doing at the time, but it seems that if you start shoving a little bit more into the primary care arena, you're going to have to provide some additional support to the practitioners to become a resource for that, which may be, at least in theory, a way of taking one person and applying it to multiple people so that you get a cascading effect. I don't know how practical it is because I don't fully understand treatment here, but
yeah, Jeff, one example is, we have some larger clinics that might contract with one licensed behavioral health provider, and they go to different sites. So they cover a wide swath of an area. They're able to provide some broad behavioral health supports, but they're not linked to one particular site and tied to one area. So there are ideas out there. It's just which ones make the most sense from both a resource and a financial perspective here.
Yeah, there's another issue hidden in the data, and that is when you look at capacity and all that, there's a significant difference between metropolitan and rural, and the number of providers in the rural is a little bit more than half of what's available in a metropolitan area. And since Oregon is from a land standpoint, 80% rural, and even, I don't know, JJ, do we count you as being rural down there?
Yeah.
So
yeah, we're a very rural community.
Yeah, access is like, wow, what a challenge that is. I mean, this is a huge uphill push. So I think to some degree, we need to understand what the standards are. The fact that a provider or carrier says we have standards, so what are they? And how big is the gap in terms of what you're providing is something that we need to know.
And is it that they're bumping up against a workforce issue, or is it a contracting issue, or is it a reimbursement issue, or is it a combination of all of those? Like today, you wouldn't be able to answer that question.
Yeah, and I mean, I think you pretty commonly hear about reimbursement, and I understand that even Medicaid pays more than what our plans pay.
I'll have to defer to Emery on that. I'm not sure if that's accurate or not.
Yeah, that so far we can put that in the hearsay column, but I'd certainly like to believe that we're providing at least the same level to the people we represent as Medicaid. And so I think there's more for us to know is the bottom line here.
We would agree with that.
So Cindy, I'm sorry, go ahead.
Well, I'm wondering whether we convene kind of a roundtable with the carriers and find out what they have to say about it.
Jeff, I think you were gone when I said I had sent a note to Glenn Bailey that we'll get this shortly on COUT, so we can look at it at least from that perspective.
Yeah.
And if you want to make it, if you think we should carve out and make it a dual PEBB OEBB activity, we sure could do that. because I think the issues are very similar.
I agree with that. I think this is a huge issue. And,
That would be
you know, it rolls into other areas of healthcare. So,
Yeah.
It does, and I would say that when we looked at the contracts as they stand today, we were specifically focused on behavioral health, but the network adequacy requirements that we would expect to typically see in a contract weren't there even for other types of providers. So it wasn't just behavioral health provider network standard.
yeah, I'm sure there's room for us to at least bring a bit more definition to our contracts, not necessarily that we tighten the noose at this particular point, but we don't know where to tighten it at the moment.
Right.
I don't even think we have good measurement of outcomes. I mean, are people actually benefiting from the treatment that they're getting?
Right. Yes, Cindy, just to your point earlier, sorry. Camera's not gonna work well here. Yeah, so just to your point, we may not be able to solve all of this, but at the very least, we need to look at what we do have in our control contractually and make sure that all of that's firing on all cylinders, so to speak. Because
That and getting the information that you need to make other decisions.
right, exactly. I mean, at least, if you're facing a bad situation, that's no reason to throw up your hands and be like, well, it may as well all be a mess. It needs to be, we need to be performing really well in our administrative and contractual arrangements in the face of a very challenging environment. And I think right now it's kind of a double whammy where we don't have things situated where we want them contractually and there's not enough providers. So it's sort of like this double whammy, not to mention the pandemic's weight on the system. So, yeah.
And I would also add that you hire, when you go through the procurement process, ideally you're hiring best in class carriers who can help you start to solve some of these really complex problems. So, Margaret, I know we might be bumping up on our time. Does it make sense for us to review a few of the high level EAP findings and then just go into the final summary of findings in interest of time?
Yeah, let's check in on the agenda. A couple of things.
Okay.
So we are a little bit over on time. We do have the hospital data presentation to follow this, and we also were scheduled to take a break in there. So, Jeff and the rest of the IW members, what are your thoughts on how to tackle the remaining time we have?
I think I would kind of throw it up for discussion. The hospital utilization, is that something we could postpone for a month, or do we think we've had enough of this subject for today and then revisit it at the next meeting, provide some more time for discussion and hopefully benefit from some further thoughts by our consultants?
I think we've had enough of this for now, and we do need to do some additional work. There's lots of question marks, and so my hope would be that we very important conversation. It's not going to be solved today. We need to come up with a. I need to reread all the findings and think more in light of our conversation, and see how to proceed.
Sean, what do you think?
I agree with that.
JJ? Agreed. Okay. Let's take a 5-minute break.
That's fine.
And come back to the hospital utilization analysis. Okay. Thank you all. Cindy, thank you that you have stimulated us.
Thank you so much, Jeff.
Hey, Dan, I think your microphone's still on. You might want to mute.
Yeah, Will, thank you.
Emery, are you doing your own slides?
No, I can call out for changes in slides
Okay.
if that's okay. Thanks.
Okay, I was just checking.
Jeff, I want you to note I've changed locations.
Glad to know you're moving.
Yeah.
Stationary is the new smoking, right? I think we got everybody, I believe. Well, I can't see other pictures other than Emery and you, Tom. JJ, you there?
I'm back.
Sean
Ready to go.
and Margaret.
Yes, I am here as well.
Okay, let's go.
Okay, well, thank you. So I'm here to present the hospital monitoring report. We had talked maybe a year and a half ago about trying to look at potential impacts of the 200% of Medicare reimbursement change, as well as maybe some unintended consequences. And this is our first report on the CAP results and the utilization. And based on questions, we may have additional follow-ups, but wanted to go through some of the, in terms of the agenda, some of the original savings projections, so we can have, ground ourselves in what we originally thought might happen, and some of the initial results, initial findings, overview of those. And then we'll potentially break out into inpatient, outpatient results. And then Jeff, based on your request, we did take a look at some centers of excellence procedures and the facilities that are performing them. And then just next steps in appendix, where there's additional data, which is just a small subset of the kind of information that we can produce, or additional questions that you may want to ask about, so we can create those as well. Any questions before we move on to next slide? Nope. Okay. So wanted to kind of go over the data assumptions. PEBB and OEBB are actually, we've looked at it on the plan different basis for PEBB and OEBB, as the plan years are different, as well as the implementation of the 200% Medicare cap. So for PEBB, everything's on a calendar year. So when I refer to 2020, or basically the most recent time period, it is on a calendar year basis. For OEBB, the time period is shifted back. So it's an October 1 through September time period. So just kind of keep that in mind. It's not exactly on the same time frame, but we're trying to get it, I guess, as apples to apples, pre and post cap in this case. We did look at data for all medical plans and carriers. So Moda, Providence, and Kaiser are included, and we didn't. This is basically all lumped together. We didn't do breakouts, although that is possible. There were some data limitations and some assumptions. I think there had to be a decent amount of data cleanup to try to identify facilities, and we're not, in some cases there were some issues with the data, the way it was I guess potentially produced or fed into IBM Watson, where we're not able to really say definitively, these claims were for a cap facility versus non-cap facility, and there were some procedure codes that kind of got all lumped together, and so that actually does have a little impact on one of the slides, but we try to work around that as much as possible, and I think there's a lot of information that we or findings that we could glean based on what the data actually showed us. Okay, actually, Rose, let's move on to the next section. Thanks. This slide is a repeat of some of the prior from prior presentations, just kind of giving you an idea of the initial analysis that we were anticipating in terms of savings. For inpatient, the analysis said it was about 235% of Medicare compared to the 200% cap for these cap facilities. So there would have been 15% savings potentially for inpatient. Outpatient, the percentage of Medicare on average was about 284%. So we're expecting closer to a 30% savings for outpatient. And then in total, at 260, blended between inpatient and outpatient. So we were saying about 23% in savings, and the dollars based on what was provided, I think it was for annual dollars, would get us to about $80 million in savings for OEBB and PEBB in total. If we move on to the next slide. The initial observations for inpatient and outpatient. And so I guess the biggest question is, did we come close to those savings? And it does appear that savings are lower than what we originally projected. Outpatient, it was, depending on the services you look at, there's some mixed differences and stuff, issues, but mixed differences, you're getting, it says under 15%. It probably actually was a little bit higher than 15% for outpatient. So you're getting pretty kind of close to what we had originally projected. But for inpatient, we actually noticed that it doesn't look like we really got savings. And the result, the issues with that is some of the DRGs, average allowed amounts per DRG admits, actually didn't change or very much as a result once we took a look at the two different time periods. But for newborns, the specific newborn DRGs, and we'll go into a little bit more detail about this, the CAP facility per DRG cost basically doubled. And as you might expect, there are a lot of newborns, especially in the OEBB population, and PEBB as well, and that potentially outweighed any potential savings on the inpatient side.
So, Emery, let me make sure I understand what you're saying. Are you saying that the allowed costs for Medicaid doubled for newborns, and therefore our cap for newborns doubled? Is that what you're saying?
No, actually, so it's actually a percent of Medicare. Just.
Oh, right, Medicare.
Yep.
Sorry.
Yeah, so it's percentage of Medicare, and I think this was brought up. I believe MODA had talked about this, at least with the consultants, and I think we may have talked about it in the IWG, where I think, well, actually all plans pretty much, the contracting with the hospitals, some of them may have been below 200% of Medicare for certain services. I think high volume services like maternity would be probably one of those where they were getting a better rate than 200% of Medicare. Once the contract went into place, basically all the CAP facilities, from I think what they told us, went to 200% for across the board.
Oh, okay. So they were way under 200% before the law change, and then after the law change, they brought up their prices, as if treating the law as a minimum rather than a maximum.
Yeah, it does appear that it was the case, and I think there's a question. There's a hand.
Yeah, it's James. Because there's not much maternity in Medicare, the Medicare payment for newborns isn't that precise or probably that competitive. So this is an area where saying we're going to only pay 200% of Medicare may have had a unintended consequence, because Medicare uses the MS DRGs and most payers use like an all payer DRG. And so I think it was an opportunity to not increase to 200% of Medicare, but by doing 200% of Medicare, it also was more than we used to pay. In most cases, going to 200% of Medicare might be less than we used to pay, but not for newborns.
Thanks, James. Any other questions? Okay, so that was pretty much, that's one of the bigger findings, I think, especially for the inpatient. A couple other sections, potential COVID impacts, just so you know, some things that we saw. It looks like elective surgeries did decrease during plan year 2020. So on some of the slides, you can see certain services that might be more considered elective, like bariatric surgeries and spinal fusions, did drop for Oregon. Colonoscopies decreased as well. I mean, I don't know if that's necessary. I mean, it's, I guess, kind of elective. I mean, preventive care services. So those did decrease as well by 20%. So there was some definitely results of COVID and deferral of care in this case. And then there were some increases in care in terms of COVID testing claims. For OEBB and PEBB, the data shows about 1.5 million, over 1.5 million just for testing was paid or allowed in this case. A little bit more detail on the data issues. We did try to clean it up, but we did the best we could, and hopefully it's close to what it's close to the information then that it's valid comparisons in this case.
So Emery, I need to be really clear on this point. Mm-hmm. So setting aside for the moment the pandemic and deferred medical care, etc., what you're saying is the policy of 200% of Medicare was for them almost entirely ineffective because we didn't save any money on inpatient care because the facilities, the system raised their prices for maternity, basically maternity care, up to 200%, where it was well below that, and so it basically offset any savings that we realized in other areas. Is that correct?
I would not go that far. I think for inpatient only hospitals, the increases in the maternity may have outweighed any other savings as a result. For outpatient, as we go through it, as we compare the different services, different procedures, potential outpatient surgeries, there definitely were decreases in the allowed amounts that went
in
through.
Outpatients.
Yeah, in outpatient. So
yeah, but
overall,
speaking of the hospitals, we saved
outpatient
nothing.
facilities, hospitals.
Okay.
So I guess for just to clarify for this analysis, when we're taking a look at it, we're trying to look at services performed in facilities potentially that might be capped, as well as facilities that would not be capped. And generally, we're trying to look at the hospitals. I guess Tom was talking about the 50 or so hospitals in Oregon. So we were kind of trying to focus on that.
Yep. Who else have you? Are we the first to hear this? Who else have you shared this with yet?
It's an IWG exclusive.
That's exclusive. Nobody else has seen it.
Okay. We should probably share this with our legislative partners.
Mm-hmm. Yeah. Yep.
Let's talk about that in a few minutes.
And just to note, Emery, so this is Margaret, and you may not be able to answer this, but we had revisions put into effect on the rules at the end of last year. It was December 2020. That clarified criteria around lesser of bill charges or the 200% of Medicare cap. So I'm wondering, and I know this data we're looking at is calendar year 2020 data, and those rules, those revised rules were put forward early in 2020, and they were put on hold after the pandemic started, and were put into place at the end of 2020. So I guess I'm wondering theoretically if that provision of the rules would potentially address some of what was observed with the maternity claims and those costs going up. And so I guess I just want to call that out, that is a change we implemented at the end of 2020 to tighten up the administrative rules.
And there was a decent amount of retro adjustments, right, Margaret?
Yeah, there were. I don't recall off the top of my head the volume in terms of dollar volume, but there were. Well, hang on a second. I'm thinking I'm sorry, I'm backing up to last December. let me clear my head. I do believe that those rules were implemented on a prospective basis, if I'm not mistaken, and I can go back and check, double check our meeting minutes from the December board meeting to clarify that.
I think you're right, Margaret.
Yeah.
So that trying to put the best spin on it, we should see more savings as we go forward with the cap chart.
It would seem so, and I think that could be, a next step, definitely a next step. I mean, in terms of looking at some of these inpatient DRGs and services post 2020, we would be able to maybe see the impacts of that.
Okay, can't cry over spilt milk. Let's keep moving.
Okay, moving on.
I mean,
just go ahead.
To put a fine point on it, like I am deeply skeptical as to whether we will see savings. I mean, the hospitals have made it very clear that this is their enemy and they will fight it. And they won this last year. And so I just want to put that out there. I do not think it will be an improvement. I think they will find a way around it. They found a way around it. The rules were clear the way they were written previously, that they were not to do this, but they were like, they played dumb and were like, I didn't know. And so, yeah, I'm not counting on that.
We'll put that in the record, Sean.
I mean,
I'll also say that I know we had a meeting in OEBB with a number of hospital administrators, and to be frank, they were just whining about how we didn't pay them enough. And I'll repeat my general stance that our healthcare system is fairly broken because it's fueled by greed, and we were worried that we hit them with a hammer and over on the left in order to prevent overpayment, and they'll just move the money to the right, and that's exactly what they did. Hospital administrators are highly paid professionals that are designed to rape and pillage the system, do as much as they can, and they have done a successful job. I will say the hospital cap is more a tool to limit future growth than it is immediacy of savings. So I do think there's some value long-term of it. That being said, hospital administrators are smart folks that are designed to, reap the highest profit margins for their stakeholders, and they have, in all likelihood, successfully done that in the last year.
Actually, before I move on, Jeff, do we have do you want to do a hard stop or at 4 o'clock, or I just want to know like how to plan the presentation, because that's 15 minutes from now.
Let's go to 4. We can pretty much count on a short time turnaround on public comment.
Okay.
So.
Okay. All right. So a focus on inpatient hospital observations here. I guess one of the big worries we had was potential shift between capped and non-capped facilities. Did not notice that in the data. Both PEBB and OEBB had about 75% in the most current year, and that's actually the same or just a slight increase from the prior year. So there wasn't shifting of capped from non-capped to cap admits in this case. The allowed cost per admit actually increased 4% on average for capped facilities, while the non-cap saw a 6% decrease. Some of that may be a shift in the type of services, the DRG mix, but that's a little bit of an unusual finding when you put in the cap, 200% cap on payments for certain facilities, and ends up costs going up on average a little bit more than the non-capped. I mentioned before newborns, and there's one I think item there. We do show Washington and Idaho kind of broken out for potential shifting. For OEBB, there was a large claimant, $9 million large claimant at Seattle Children's, so that kind of skews the data for OEBB. And so, to try and take a look at on the average basis, it increased the average cost quite a bit because of that. Little breakout between OEBB and PEBB. The allowed per admit at cap facilities, OEBB's costs actually increased a little bit more than PEBB's. OEBB's was about 8% per admit, and then PEBB was about a 1% increase. At uncapped facilities, both were about 6 to 7% decreases. A little bit more detail on by DRG there. So the specific DRGs, they had increases of about 100%. 794 through 793, 794, and 795. So increased 104% to about 172 for the neonates with other significant problems. I don't know if this is a just random statistical noise or COVID or anything. The DRG for psychosis admits actually increased during the most recent time period, and the allowed per admit did increase as well. So, so potentially longer stays and more admits for psychosis in this case. Average cost in CAP facilities for the top 15 DRGs did increase about 11%. There are other DRGs that may have brought down that increase, but at least the most noticeable ones had the big increases, which also included the newborns and maternity. So that kind of skewed the data a little bit. A little bit of information on COE services. So I tried to, based on information from Willis Towers, take a look at the outpatient services that might be COE services based on procedure codes, DRGs as well, and diagnoses to try to match up, types of COE services in this case, and allocated by the different facilities. The admit for DRGs actually decreased for COEs for plan year 2020, which is ties into the reduction in elective services. COE services are pretty much elective, and there is reduction in that case. One thing to note that was a little bit interesting, and I think found for PEBB as well. 86% of surgeries were performed at capped facilities, so that 86% of COE services were, there compared to 75% for all admits at capped facilities. So I think this implies that their members do travel to certain facilities for these COE services. So the travel restriction or requirement may not be as onerous for a lot of members because they're actually currently traveling. And I think for PEBB, when we had dove into it, we had found that people did travel to certain places to have, knees or hips and back surgeries. Total admits did decrease 28%. Costs decreased 1%. CAP facilities saw that 28% decrease. Outpatient costs for COE services actually decreased, while the inpatient costs for COE services increased. So that kind of ties into the inpatient outpatient cost differential mix, I guess. So for COEs, it was in line with what we saw for overall inpatient outpatient mix. Any questions before we move on? Okay. So these next few slides actually contain some detail. We're on it. So what we show on actually the next three slides are kind of like, this one's OEBB and PEBB, but the information is kind of similar across the board for OEBB and PEBB specific on the next two slides. I won't go into really any detail on this. A lot of the information was shown before, but we broke it out by capped hospitals in Oregon. And so the total number of admits there's just over 8,370, which is the 75%. Uncapped hospitals had a little bit under 1,900, or about 17% of admits. Washington had 6%, and then Washington, Idaho had 6% of the admits, and then there's other locations that had admits as well. OEBB had about 47% of the total admits, and then PEBB had 53%. OEBB's admit costs are a little bit higher than PEBB. Some of it's due to that $9 million Washington large claim. Moving on to the next slide. Basically, the same information for OEBB here in this case. Just a couple of other data elements that included in here. The percentage complications and the percentage day outliers, just to kind of see if there were certain complications or if people were in the hospital for longer than, in this case, what IBM Watson would expect for that specific DRG. In general, it's about 7.1% complication rate for CAP hospitals, a little bit higher for OEBB at 8.1 versus the 7.1 overall. The uncaps actually quite low at 2.6. I went read too much into that because the types of DRGs, the types of admits probably differs quite a bit between the two, capped and uncapped. And so if you have a lot more complicated admits, then you're probably going to end up with more complications in this case. The day outliers generally is about 1.1%. Washington had a little bit higher in this case, but small sample sizes, so a few numbers. Or in particular, I mean, if there's like mental health, substance abuse, that could skew that result as well. And then 2019 information's there for comparison. So the percentage of admits for capped facilities went from 73% in 2019, plan year 2019, to 75 for 2020. So no real obvious switching between capped and non-capped in this case. PEBB is on the next slide. Thanks. The number of admits is about 4,500, which is a decrease from the 4,800 for capped facilities in 2019. 74% to 75% of admits were at capped facilities. And the complication rate's pretty similar to what for OEBB. And in terms of the mix as well, uncapped facilities don't have as many complications compared to the capped facilities, probably because of the mix again, in this case. If we don't have any questions, we can move on. Actually, let's move on to the next slide in the interest of time. So this shows the top 15 DRGs by total dollars, not admits, but total dollars paid. And this one's for capped facilities. The prior slide was for both for Oregon, capped and non-capped, but this is capped specifically. So we can take a look at some of the changes. So the admits are listed there, the various DRGs, and the change from 2019. The changes from 2019 don't differ too much. There is one potential COE right there, DRG 470. There's a small decrease in number of admits for that service. And then the allowed per admits, you can see, are listed there, and then the change from 2019. The big ones that increased, the second one, the neonates with other significant problems, increased to 172%. Normal newborns is row 5, that increased to 104%. And so to about 8,400. So, it's about $4,000 before, and now it went up to $8,000 for the 738 newborns. And then full-term neonates also had 100% increase, and that was more of a $20,000 plus increase per admit on average in that case. The medical back problems, that one actually had a little bit higher cost increase as well, 13.5. Most of the others were kind of flat or small increases in this case. Any questions?
The increase in normal newborn by 100% is pretty outrageous. I'll just say that. I don't know if I can't do it with neonates with other significant problems. That is one that can bounce around and again, high cost claimants and things like that. But a normal newborn care at averaging at 8,000. No, it's.
I cannot tell you how outraged I am. I appreciate the analysis, Emery, and want to be sure that it's clear that it's not like shooting the messenger or anything like that, but this is outrageous.
Yeah, and for comparison, I think just taking a look at row 5, normal newborns on this slide. This is the uncapped facilities, so the average allowed per admit is $3,000 compared to the $8,000.
Yeah, that's just outrageous, and I mean that needs to go. That needs to go somewhere.
This is the example of what's wrong. This is the example right here. Like everyone's always trying to pin it down, like, oh, where is it? Why is it so? Like right here. This is it.
Yeah. So I mean, if you have a little more time, like comparing the two slides here, especially for the maternity, if you want your blood pressure to be raised, you can take a look at that.
We'll put something like that together, Emery.
Okay. Yeah, definitely. Yeah, so we only have a few minutes left. So moving on to outpatient facilities, 2 slides down. And my cat wants to join the conversation, apparently. Hopefully it's not going to be too loud. So outpatient total procedures decreased by 8%. I think ER visits also decreased for CAP facilities by 6%. Total visits decreased by 13% in that case. Allowed per service did decrease, for outpatient services in this case. And in comparison, for CAP facilities, it did decrease by 12%. In comparison, the Washington, Idaho facilities allowed per service increased 6%. So, the 200% did have impact here compared to some other places. Procedures, a little bit more detail on OEBB and PEBB. Similar story across the board. I think the other thing that I've found a little bit interesting was the ER, and a little bit on specialty drugs as well. So most CAP facilities had decreases in ER visits. Kaiser Westside actually showed an increase, but that's actually data issues. Some 19 prior services weren't able to be classified correctly into Westside, so ignored that difference. But the one interesting thing, and unfortunately I'm not going to be able to get into detail, but the level 4 and level 5 ER visits, the highest severity visits, continues to increase, especially at CAP facilities. So there might be, I think this has been an issue in the past, but it continues to be an issue.
It's also the impact of COVID with fewer people going with minor issues to the ER. So there is going to be some concentration effect.
There is some concentration there. And you can take a look at the slide. I think it did vary by facility. The bigger ones were legacy facilities. I think all of them kind of increased by almost double digits. Peace Health, Riverbend increased by 10%. There is a slide on J codes, and good news here. The cost per J code service, so these are injectable drugs, did decrease by 26%. So, specialty drugs, at least in the outpatient facility, went down. Did not look at, offices. I mean, that might be something interesting to see if, potentially in the office setting, they could make a little bit more money or charge a little bit more. And there might be potential shifting there. We didn't actually, dive into that, but that may be something for future analyses. And then outpatient events, these are kind of like basically outpatient surgeries. Cost per outpatient event did decrease 20 to 30%. Elective surgeries, the services did decrease, and some outpatient events, outpatient surgeries, colonoscopies, MRIs, some other services are there. And actually, I think that unfortunately takes me up to 4 o'clock. So I will stop here.
That's probably good. I don't know if I could take any more, but it's really good information though. Thank you.
Yeah, definitely take a look at it, and bring it up in meetings, send us emails. If there's any other things you want us to.
This will not be the end of the discussion, I assure you.
Release the hounds.
Yeah, basically.
Well, what a stimulating meeting we've had. So we have the same agenda next meeting, Margaret?
Well, we will plan that. We had some additional topics to cover next month, but I think that we can certainly regroup and determine what we want to carry over and continue some discussion on.
Yeah.
Yeah.
Obviously facetious, but not entirely.
Not entirely, sure. It was a lot of information this month.
Well, thank you all for your reports. I guess that's a good sign that you completely captured our interest. The bad sign is that there was interest to be captured there, I guess. Do we have any public comment? Question to headquarters. Rose?
I'm sorry. No public comment.
Okay. Any final comments before we adjourn?
Appreciate that everyone gave me something new to be mad about. I was just focusing on COVID, so this is great.
Good work, JJ. Go get him. Go get him.
Okay. As I said, meaningful meeting. It's now
It
adjourned.
is. Thank you.
Okay.
Appreciate it.
Bye all.
Bye-bye.
Thanks, everyone.